type in questions. All questions will be answered at the end of the webinar. Thank you in advance. Today we'll provide more details on attribution and the ACHN. Specifically today we'll discuss the definition of attribution, some of the guiding principles driving the methodology behind attribution, some of Medicaid's key process steps, including how the point system will work, 3 illustrative scenarios that will provide examples of how recipients can be attributed to any provider group. Finally, we will end the webinar with reconsideration processes and then open it up for questions. What is attribution? Attribution is the process that will be used to associate a given Medicaid recipient to the PCP group that is providing the primary care to that recipient. As a reminder, PCP groups must sign 2 agreements, that is, one with Medicaid and one with the ACHN entity. Under the ACHN program, Medicaid recipients will be attributed at the group level based on historic claims. Therefore, PCPs are encouraged to continue seeing patients as medically necessary to increase the likelihood that that recipient and group of recipients will be attributed to their practice. You'll see later today, attribution is a critical factor in determining the distribution of our bonus payments among our eligible PCP groups. It should be noted, attribution will replace panel assignments. As discussed previously, beginning October 1, under ACHN, the Patient First program will cease to exist and capitation payments will no longer be paid. We would also like to note a current panel should not be compared to your first attribution list, and a smaller number of attributed members compared to the previous panel does not necessarily equate to a reduced payment, and we'll walk through some examples of that. How does attribution impact our payment structure? As a reminder, and you've seen this in previous webinars, the new payment structure beginning October 1 includes enhanced fee-for-service rates. However, attribution only impacts the bonus point determination and around quality metrics, cost effectiveness, and patient-centered medical home activities. Future webinars will cover those specific methodologies. But for today, we'll talk about attribution's impact, particularly in year 1. This next proposed timeline illustrates how attribution affects bonus payments in year 1. In fact, year 1 is the sole determinant of year 1 bonus payments. In future years, attribution will play a key role in how we determine quality, cost effectiveness, and PCMH recognition. Again, more details on these specific methodologies will be covered in future webinars. Before we get to some of the details, we wanted to provide an overview of some of the guiding principles behind our methodology. First and foremost, these principles are consistency with ACHN's principles of paying for activity, not only paying on activity, but continued emphasis on care coordination and a focus on health outcomes. We also want to acknowledge that some recipients do in fact require specialty care, at least for a brief period, for their primary care. In other words, a PCP group's outcomes should not be affected by that particular recipient. And finally, evaluation of activities and bonus distribution will be made at the group level, and we'll go into further detail about that. Now let's cover some key process steps. Number 1, only recipients that have met criteria for the ACHN program for any 3 of the previous 24 months will be attributed. And I would note this does not have to be a continuous period. For this previous 2-year history of face-to-face visits, frequency of visits and recency of visits are awarded higher point values. Also, PCP visits will receive a higher point value than specialist visits. We will discuss this in more detail later. And finally, the previous 12-month history of filled prescriptions for maintenance medications will also be scored. How will the process actually work? On a quarterly basis, the agency will determine attribution for each recipient under the ACHN program criteria in accordance with the following process steps. First, point values for face-to-face visits will be assigned to the performing provider that performed the service. However, the individual practitioner scores will be combined to form the PCP group's total point score. This, of course, assumes that there are multiple providers in any given group. Finally, the PCP group with the highest number of points will have that Medicaid recipient attributed to the group. And as mentioned, if a specialist group happens to have the highest number of points, then the specialist group would be attributed the recipient. Now we're going to go into a little more detail on how the point allocation system will work in attribution. There are three primary components as seen on this table. First, points will be awarded based on primary care or specialist designation. Secondly, points will be different based on if the visit is a regular visit versus a preventative visit. And finally, the recency of the visit will have different point systems. So, as an example, on this slide, a recipient, if you look at the number 8, a recipient within 0 to 6 months in the chart that had a preventative visit to a primary care specialist would have 8 points attributed to that particular provider. And standard visits are noted, or regular visits are noted with the CPT codes at the bottom of the chart. An example of one of these CPT codes is 99213, which is a 15-minute office visit. Preventative visits also include procedure code ranges. An example of one of these is 99383, which is a preventative reevaluation of an established patient. And finally, various maintenance medications will be awarded points based on the recipient. These include allergy and asthma medications, PPIs including omeprazole, among many others. This is a high-level overview of how the point systems will work. What we'll do next is walk through 3 illustrative scenarios of how any given recipient could be attributed to a group. These are only 3 scenarios. There are several different scenarios which will actually take place once we begin assigning points to recipients and provider groups. So for scenario 1, this focus for this example is on the frequency of visits. In this particular example, our member, Stephen, sees 4 different providers across 2 different provider groups. As you can see, 2 of these visits were made with Dr. Hardy, who is with Apollo Internal Medicine, and 1 visit is with the 3 other providers. In this example, although Dr. Hardy, who is with Apollo Internal Medicine, had the most individual visits, Apollo Internal Medicine only received a score of 4. But the member in this case would be attributed to Gallagher Family Practice. The reason being is our member, Stephen, had multiple provider visits within that group. So in this scenario, Gallagher Family Practice would be awarded 6 points, while Apollo Internal Medicine would be awarded 4 points. Our next example focuses on frequency of visits. In this example, our recipient, Jane, sees 3 different providers across 2 provider groups. This particular member's 2 most recent visits, in this case, were to Bluebell Pediatrics, and the older visits, 3 older visits, were made to Princeton Plainsboro. So although Princeton Plainsboro had the most visits by this member, the group only received a score of 6 as a result of the older visit dates. Therefore, the member is then attributed to Bluebell Pediatrics as her most recent visits were made to this practice. In this example, Bluebell Pediatrics would receive a score of 8 versus the score for Princeton Plainsboro of 6. And finally, scenario 3 in our list gets a little more complex, but the primary focus is on both frequency and recency of the visits. In this example, our recipient, Denny, sees 3 providers across 2 provider groups. And in this example, one provider actually belongs to 2 different provider groups. 3 of this recipient's visits were made to an individual provider, Dr. Montgomery. Dr. Montgomery is in 2 provider groups. Seaside Health, one of the groups, received a score of 4 based on the total number of visits and visit dates. But again, the member in this case would be attributed to the Gray Sloan group because they received more visits and more recent visits. In this example, Gray Sloan received a score of 8 versus Seaside Health, who received a score of 4. Now, before we go to the question answer, I'll turn the presentation over to Drew Nelson, who will walk through our attribution reconsideration process.
Thank you, Barry. So attribution will be calculated on a quarterly basis, and the reports will be published to the providers. The reports will be published just like if you're a current patient first provider. Now you get your monthly patient enrollment, your panel. That will go away and instead will be replaced by your patient attribution reports that will occur the first of every quarter. We encourage, and it is the responsibility of every provider, to review that attribution list on a quarterly basis. It will be released. The first one will come out later part of this month and will be in your box in the web portal no later than the 1st of October. Every PCP must review that report if they have any concerns. A PCP group, after reviewing the report, may request an attribution calculation for any Medicaid recipient who has received care from the group from the previous year or previous 2 years, but has not shown up on their attribution report, and they believe that they should have been attributed to them. If the PCP groups believe they have not been attributed, the group may request the agency to reconsider the attribution. The request for reconsideration must be submitted to Medicaid Agency in writing and within 7 business days of the quarterly attribution notification. A written request for reconsideration must contain 3 components: the period for attribution, the name of the Medicaid recipient that the PCP group believes was or was not properly attributed. Also, if you can include the Medicaid ID number, that does make the search a little bit easier. And supporting information or other documentation demonstrating that the Medicaid agency either failed to or improperly considered information which had a material impact on the result of the attribution. This should be submitted to the agency's network provider assistance group, and you can email that to Travis Hauser at Travis, Travis.Hauser, Houser, at medicaid.alabama.gov, and that information will be posted on the website. The PC group, continuing with that, the PCP group that was originally attributed to the Medicaid recipient, subject to the request for reconsideration, shall be notified by Medicaid and be permitted to submit any additional information within 3 business days of that notice. So basically how the process will go is if you see your report and you don't see Jane and you believe that Jane should be attributed to you, the PCP who has lost that patient, would submit an email to Travis or submit a letter within 5 business days. The agency must receive it within 5 business days of the report going out, saying that I have seen Jane the last 2 months. Here's why. Here's the documentation. Here's where y'all pay claims for Jane coming to visit. In the meantime, the agency will, once we receive that notification, will reach out to Dr. Smith, who Jane has now been attributed to, and say there has been a consideration for redetermination submitted for Jane. Please submit any additional documentation that you might have to prove that Jane has gone to, should actually be attributed to you. The PCP group that Jane has been attributed to, so Dr. Smith's office. Dr. Smith's office does not necessarily have to actually submit any documentation if they don't have any additional documentation. So the agency will continue its review for reconsideration with or without Dr. Smith's additional documentation in this example. The Medicaid Agency will review all relevant information and complete any adjustment to the PCP group's Medicaid recipient attribution within 7 business days of receipt of the request for reconsideration. The reason why you will notice it is a very quick turnaround is so that all of the attribution as well as all of the redeterminations can be dealt with prior to the bonus payments being submitted. So, for instance, this month, the attribution report will be run very close to the 1st of October. So all providers can see the report come in the 1st of October. We can deal with any reconsiderations that might come in, and that therefore we can submit all quarterly bonus payments the 1st of November. This is why this month, the first quarter's bonus payments are off 1 quarter. Moving forward, the next attribution report will come in the 1st of November, so that we can have everything run and taken care of through December and have the bonus payment submitted 1st of January, so we get back on the quarterly basis. All right, I'll turn it back over to Barry.
Okay, we will begin our question and answer session. Before we do so, however, we wanted to go ahead and provide answers to both anticipated questions and questions that we've had in the past. So hopefully this will cover some of the questions that might be posed today. First, it was mentioned earlier that attribution lists will be smaller than panels, but that the bonus or the money will not necessarily change. How is that the case? Again, attribution lists will inherently be smaller, given that at least one face-to-face visit is required for a member to be attributable. Also, remember, there's an added requirement that patients be eligible for at least 3 of the previous 24 months. So all ACHN recipients won't necessarily be attributed at this point. Another question is, will the bonus be paid to individual providers or paid to the group? Again, we've covered this, but the bonus payment will in fact be made at the group practice level. It will be at the discretion of the practice relative to how the bonus distribution will be divided among various providers in the group. Third, if I practice at both a private practice and an FQHC, where will the patients I see at both be attributed? Again, given that attribution is made at the group level based on frequency and timeliness, these particular recipients would be attributed to the group with the highest point level. How many times must I see a patient to have them attributed to me? Again, that depends. If you're the only provider a patient is seeing, it is likely that you would receive the attribution after only 1 visit. However, the number required for attribution varies if the patient is also seeing other providers. And finally, a frequently asked question is what are the general similarities and differences between panels and attribution? I would reiterate that comparisons should not necessarily be made between current panels and attribution because the money is going to be distributed differently. Really, the only major similarity between the two is that they both match a Medicaid recipient to the provider. Some of the notable differences between panels and attribution include panel assignments are given prospectively, while attribution is a retrospective analysis. Also, panels include all eligibles, including some that providers have actually never seen. Attribution includes eligibles, again, that have had at least 1 visit to the provider and have been eligible for 3 months of the previous 2-year period. Panels are assignments to a specific provider, while attribution relates to provider group. And finally, panels determine capitations. Capitation goes away. Attribution determines percentage of the bonus pool, which is very important for the major differences between attribution and panels. With that, we'll open up the forum.
All right, we'll start with a couple of questions. First one is a slightly off one. Do optometrists have to sign an agreement with the ACHN to continue to see Medicaid patients? No. If you are just going to be a specialist, you do not have to sign an agreement with the ACHN. You would still be able to see Medicaid recipients as you normally do. How will newborn babies be attributed? Newborn babies will not be attributed until after the 3rd month of care, because they have to have 3 months of the past 24 months, which would mean they have to have 3 months of eligibility and claims before they would be able to be attributed. So if the patient is attributed to a specialist, how will we, the PCP, need to get a referral from the specialist? And the answer is no. You will only need a referral to see a specialist. So if a patient happens to be attributed to a specialist, you would still, as their primary care provider, still be able to provide a referral to them. The specialist would not have to issue another referral. We are a fairly new practice, but we have added a tremendous amount of new patients. They may have only been coming to us for a few months. How do we move them to us if they are attributed to another office? Well, this kind of goes back to the difference between a panel and an attribution. If you've had all these patients come in and you've been seeing them recently, then they will be attributed to you, even if they had previously been assigned to another practice. But if you have historically been seeing them, even though they've been assigned somewhere else, that's the difference with attribution, and that's one of the reasons why we're moving this route, is because we want the providers who actually have been seeing the patients and been managing their care to actually be rewarded. So that's why we're moving to an attribution logic. As a specialist who do not sign a PCP agreement, how will we know who the patient is attributed to so that we can obtain a referral? At that point on the web portal, you would only see the provider who's been attributed to them. If you happen to look and notice that they are a specialist, you would still be able to ask that patient who their primary care provider is. And if the patient doesn't have a primary care provider, that's when we would encourage you to work with the ACHN to identify a PCP for that provider. And it might be one of the reasons why a specialist has had that patient attributed to them, is because they have not been seeing a primary care provider. They've just been going to see a specialist. How often are the scores evaluated and providers attributed possibly changed?
Attribution will be made on a quarterly basis.
Okay. What if they have the same exact scores between the provider groups? If 2 providers come down to the same exact score?
The provider that saw the patient most recently will break that tie.
Okay. Does this include pregnant patients? We see them once a month and sometimes often more, depending upon how the pregnancy goes. How will attribution for pregnancy work?
The criteria for eligibility is the same for all recipients. That is, 3 out of 24 months of eligibility, if the recipient was eligible for 3 of those 24 months, and if they meet the criteria for the ACHN program. And again, the frequency of visits, the points will vary based on that.
So for a pregnant woman who only has pregnancy coverage, until she has 3 months of eligibility and 3 months of claims, she would not be eligible to be attributed to anybody. But once she has acquired that, just like the newborn baby example, whoever has been seeing her, so therefore theoretically the DHCP would be the attributed provider.
As long as she's meeting the criteria for ACHN, correct.
So this is one where an attribution could switch during pregnancy. She would go from a PCP to a DHCP theoretically. Where can we look up the attribution list? Those would be published to the web portal, just like you get your patient first assignment panels. And we only see gynecology and OB patients, we are not a PCP. How will we know where to get a referral, and can someone from ACHN call us? There is a map with all of the ACHNs on the Medicaid website, and I believe this question came from Betty. Betty, I would encourage you to go and look and see where your patients come from, and reach out to the ACHN that cover where your recipients come from. And someone's asked for Travis's email address again. It is Travis, Travis .Hauser, HOUSER, at Medicaid, MEDICAID, at .alabama, ALABAMA.gov. And that will be posted on the website as well as under the provider resources. Will the web portal still show the patient listing of patients that are due for EPSTT screenings? The agency will still continue to publish the EPSTT screening report, so that will still be there just like we currently are. And how do we check eligibility? You would still check that through your web portal.
This is Dr. Moon. Just a couple of things I wanted to add for you all is many of you probably already have received, and if you haven't, you should be receiving it shortly. It was mailed out last week. There's a pretty extensive provider insider. I want to say it's about 15 pages long that's focused specifically on ACHN. And it provides a lot of details, not only around attribution, but many, many other aspects of the program. Please also remember that there are multiple presentations that are available on our website on other aspects of the program, some of which are the previous two webinars like this one. They're already posted to our website, but there are many other webinars and whatnot that are posted to our website providing you with information. So please use those resources also.
We'll go back to some additional questions that have come in. Last week you spoke about the specialist listing that would require a referral and how specialists would no longer require a referral. Where can I find that new list of specialists that require a referral on the website? We addressed a lot of that in the Provider Insider, and the full list will be in Chapter 40 of the new Provider Manual. And we are hoping to have that out by the last week of September, if at the earliest if we can. Jerry, did you want to add anything else?
Well, I wanted to say most likely by the 27th of September on the Provider Manual.
Jerry, will referrals be needed for advanced imaging procedures?
Yes, those will be needed, just as they are today. Most referrals, if you have to do them today, you will have to do them for the ACHN.
In the first year, how much can a PCP expect to receive in bonuses per attribution?
This is Dr. Moon. Please recognize it's hard to say that, obviously, across the board. I mean, it's going to depend on how many patients are actually attributed to you. A couple of points I would make about it, and that is that this program is built around using the same amount of money and only spending it differently. The amount of money we're spending on primary care is the same. It is not less. And therefore, as a whole, what we're paying out is going to be the same. Who receives it is going to be driven by this very important topic of attribution and your scores on various parts of this program that we're talking about. Attribution is a key component in this. Even in the first year or so, when you're receiving a payment as though you earned every potential bonus, that's going to be driven by the size of attribution. So the thing you can do even today is, as the slides pointed out, as medically necessary, obviously, see your patients. Individuals out there that have large panels of patients that they never see will not have many patients attributed to them in all likelihood. Those of you that are actively working your panels, that are seeing folks that are coming in, you will probably have larger groups of patients attributed to you and will have correspondingly larger potential bonuses associated. But again, to answer the original question, in aggregate, we're spending the same amount of money. Obviously, some people will do better in the new program, others will do worse in the new program. So, but the fundamental driver is see your patients and provide high-quality care.
Okay, going back to some other questions. Will the PCPs constantly change, like with Medicaid patient first plans? The PCPs, would not necessarily change consistently. Who they are attributed to might change quarterly, but that's why we're only running attribution on a quarterly basis. And again, it kind of goes back to one of the examples where you would suspect that would occur would be the pregnancy. Until she has 3 months of pregnancy claims, she would always be attributed to PCP, but because going through maternity care and she's seeing the OB, she should be attributed to the OB because the OB is now taking a more active role managing the patient's care.
And this is Dr. Moon again. Let me address a part of that. The number one complaint that I've heard about the existing system with panels is that patients are on my panel, they lose eligibility, their eligibility gets reestablished, and they're auto-assigned to somebody else. And the patient didn't want to go to somebody else. I didn't want them to go to somebody else. The new person they got assigned to didn't necessarily want them. And all of the administrative hassles that go along with that. In the new program, starting October 1, that all goes away. If you have a recipient that you've been seeing steadily, they lose eligibility, they regain eligibility, and they want to come back to see you, all they have to do is come back to see you. So a lot of those complications go away.
Some other questions. What if patients need a referral in the 3 months she is not attributed? Well, for example, the newborn. The PCP can still provide the referral. At that point, you would just need to ask the patient or the parent or guardian, if it's a child, who their PCP is. And so that would be, again, going back, if they don't have a PCP or they don't know who it is, you can always reach out to the ACHN, and the ACHN, that's one of the things that they've been tasked to do, is to ensure that all recipients have a PCP. Do only PCPs receive an attribution list, or do DHCPs also get them? This is a great question. Any provider who has any patients attributed to them will receive an attribution list. So even if you are a cardiologist, but you have some patients who are attributed to you, or an oncologist, and you have patients attributed to you based off of the care, you would be able to see your attribution list. If a PCP has not signed an agreement with the ACHN, can a patient be attributed to them? This is actually a great question to tee up our conversation next week. Even if you have not signed an agreement with the ACHN as a primary care provider, as a participating primary care provider, yes, you can have patients attributed to that. But you will not be eligible for bonus payments unless you are a participating PCP. And we'll go into that, and that's why we put attribution first. This whole conversation about attribution really will play into next week's conversation about quality and participation rates. Also, if you are not a participating provider, you would not be eligible for participation rates. Is the Provider Insider that was mailed out available online?
It's available online. The actual mail copies won't go out until Monday or Tuesday of next week. Okay, so it has been posted.
Great. So it is posted on the Medicaid website as well. Okay, next question. The provider referring the patient to a specialist may not be the attributed provider based on these guidelines. I think this will cause confusion for specialty offices knowing what referral will be valid. Will the claim deny if the attributed provider is not listed as the referring provider? The provider referring the patient to a specialist may not be the attributed provider based on these guidelines. I think this will cause confusion for specialty offices knowing what referral will be valid. Will the claim deny if the attributed provider is not listed as a referring provider? No.
It will not deny.
As long as the referring provider is a PCP and is signed up as a PCP, then the claim will be processed. And that will occur again if someone's new or they have not previously had an attributed provider, but because they haven't had 3 months of eligibility, then you wouldn't see that, but you could still get a referral from a primary care provider. As a PCP, we can still see a patient even if they're not attributed to our office without a referral. Correct. That is correct. Recipients still have freedom of choice to see whichever PCP that they choose. Would we just not receive a bonus for that patient? Correct. That is correct. Until that patient is actually attributed to you, you would not be eligible for that patient's the associated bonus to that patient. If a patient is not on our attribution list but is a patient, how do we get this person added back to us? Or if someone wants to be seen in our office, how do we add them? Barry, do you want to talk about kind of how someone, even if they've been consistently seeing them, why they might not be attributed to them?
Again, everything will be claims based. So even though they might have recently seen them, if the patient saw another provider between that time, that other provider would receive a higher points value. So it's basically based on claims, the recency of the visit in this particular case.
We have been told that there will be no care coordinators for the month of October for new OBGYN patients. So what do we do about getting them a referral after they have been seen? We had been told that we could not see them unless they had a referral number from our care coordinators. After November 1, that is correct. For OBGYN patients, as a DHCP for your claims process, you must have a referral number from ACHN. That is only after November 1, once the ACHNs are providing care coordination. For the month of October, because there is no care coordination for new recipients, DHCPs may submit a claim for that patient because we want you to go on and see that patient and get that prenatal care started. We have designed the system and allowed it for you for any dates, any services with a date of service in the month of October to process through without that referral number. So you can see that patient. Did copays change? No. Copays have not been addressed with the ACHN implementation. If a PCP saw a patient off panel and did not get paid due to no referral, will the visit count towards the attribution methodology? If a PCP saw a patient who's off their panel, meaning they have not been previously attributed to them, and did not get paid due to no referral, will the visit count towards attribution methodology?
So they should be paid.
Well, I was going to say there's two aspects of this. One, there is no need for a primary care provider to see a referral. The PCP, any primary care referrals go away to see another PCP. The patient can choose whichever PCP. Now, going back to the other issue is if for some reason they submitted a claim, they saw a patient, and the claim was denied, for whatever reason, would that service be considered in the next attribution run?
No, it would not. It is only on paid claims.
This is Dr. Moon. I wanted to go back and address one particular issue while we've hit a pause here just for a moment. We've gotten several questions about this is not related to attribution. It actually is related back to a previous webinar we had. But since we've received the question several times, I want to try to address the answer. And that is regarding the requirement to submit a BMI associated with claims. Obviously, as Jerry pointed out in the previous webinar, that is a requirement. The question came up, well, what about recipients that are restricted to a wheelchair? The way we will handle that is if you feel like you cannot obtain a BMI, then you submit the claim without a BMI, it gets rejected, then you would resubmit it, but with a request for an override. And then we would do a manual review, looking at that case and evaluating for that. So that's the answer to that question. Just wanted to make sure we answered it since we had a natural pause here. I'm going to turn it back to Drew.
There's a question, will OB patients have to re-enroll in the ACHN program? If so, what if patients get missed or cannot be reached and do not get a referral where all doctors not get paid? Yes, let's take these one at a time. The patients who are currently being provided care coordination through the maternity contractors, that program ends 9/30. Patients will be enrolled with the ACHN starting October 1, but will not receive care coordination until November 1. OBs who are still seeing those patients, you can still see those patients. You can still provide any of the prenatal visits or postpartum care that's necessary for those patients. Just because there's no care coordination in the month of October, you can still see that patient. Starting November 1, you will need to reach out and make sure you have a contract with the ACHN so that you are able to be paid for any of the dates of service claims after November 1. All right? We have been told that delivery, 2 sonars, postpartum visit, and first visit prior to 12 weeks will be paid. What about the antepartum visits? I do know if you are an FQHC or RHC, so please submit that one and what type of provider you are to our web portal, and we'll be able to answer that type of question. When will the phone numbers be given out for our ACHN contact? It currently only shows their email address. That is correct. The map has now been updated with phone numbers. The reason we have been waiting to post any phone numbers is because the ACHN contract will not go live until October 1. So the agency does not have a contractual obligation to encourage those ACHNs to answer the phone. So their phone numbers won't go live until October 1. Just to give you a heads up, there's no reason for the ACHN to exist prior to October 1, so their phone numbers won't go live. Some of those, so if you want to get the updated chart, you click the ACHN tab and ACHN Providers, and I think it's the third from the top of the regional map, has now updated with phone numbers. Okay. Many patients have a different Medicaid number today than the number they started with. Will attribution be attributed to that old Medicaid number or the new Medicaid number? So, through a process, yes, we do realize that Medicaid numbers have been changing. A lot of them, as they re-enroll, have been switching from a 500 number to 530. The agency has been working with a process to link all clinical history between those numbers. As much as that we have the history linked between the two numbers, that history will be considered in attribution. All right. As a DHCP with a patient attributed to us because she hasn't seen a PCP and the patient needs to see another specialty type such as cardiology, will be responsible for giving the referral to another specialist.
Can you repeat that question?
As a DHCP with a patient attributed to us because she hasn't seen a PCP and the patient needs to see another specialty type such as cardiology, will we be responsible for giving the referral to another specialist?
Okay. Starting October 1, OBGYNs will be able to provide specialty referrals. And I know a lot of questions have been coming in about DHCPs. We are going to have a presentation on DHCP on September 24th at noon, and we will address all of these questions that have come in today. We'll make sure that we address them on that presentation.
What happens when a patient exceeds the 14 days allowed? Well, any visits that are not allowed and the claims would deny, those visits would not be in the attribution calculation because they are not allowed service. Will they still be allowed one GYN visit a year without a referral? We'll move on that. We'll get a response for that one later. If the patient has been seeing a specialist provider and that patient is on their attribution list, is it the specialist's role to find the patient a PCP, or do they become the PCPs themselves?
In that instance, if the recipient has been seeing that specialist, then they can continue to see that specialist. But if they really need a PCP, then the ACHN can assist that specialist in getting them a PCP because the specialist needs a referral to see the recipient anyway. They need a referral from the PCP or the ACHN to see that recipient.
Another way to put that is, say that they have a PCP and they see them once or twice a year for their regular checkups, but you as their specialist say you're their nephrologist and you're dealing with their uncontrolled diabetes. Well, because of the frequency that you're seeing them, that patient would be attributed to you, the nephrologist, even though that patient does have a primary care provider. It's because of the number of visits and how recent the visits have been. That's why they're attributed to you.
That's correct, Drew. I would add, just keep in mind the three primary drivers of this, which is PCP versus specialist, number one, the frequency, number two, and the recency, number three, among other factors, but keep those three in mind.
Okay. Next question. Even though a patient may be attributed to a DHCP, are they eligible for a bonus payment only if they have signed a PCP agreement? Please clarify for the DHCPs. So, when we talk about bonus payments, there are two different types of bonus payments. There are two bonus payments for DHCPs, which we'll cover again in the DHCP presentation. That's the prenatal visit in the first 3 months and the postpartum visit in days 21 to 56 of post-delivery. Those are straight payments in DHCPs. As long as you've signed a DHCP agreement and working with the ACHN, you would be eligible for those. The PCP quality bonus payments are only available to those providers who are a PCP and have signed up a participation agreement with the ACHN. Now, if you are an OBGYN and you have signed up to be a DHCP, but you also choose to be a primary care provider, a PCP, and willing to sign a participation agreement and meet all of the requirements of participation, and that patient gets attributed to you, then yes, you would be eligible for a bonus payment for that patient, as long as you meet the eligibility requirements for those bonus payments, which we'll cover in the next couple of weeks. So yes, just because you're a DHCP does not mean that you cannot also sign up as a PCP, but you would have to sign up as a PCP to be eligible for that bonus payment and meet the requirements for those bonus payments. If a patient sees us but is attributed to a different PCP and they need a referral to a specialist, can we send that referral, or do we have to be the PCP that they are attributed to send us? Yes, you are eligible to send a referral. You're treating that patient and you need, under your clinical judgment, to see a specialist, then you may provide a referral to that for the specialist. If the PCP has only seen their patient 2 or 3 times during the year, but the patient has had to see the referred specialist 4 to 5 times during that same year, who would get the credit points for the patient?
Again, it depends. It depends on the number of those visits. It depends on the frequency. That is, if it was within 6 months versus 6 to 12 months. And finally, the PCP inherently receives a higher score than a specialist.
All right, if a PCP saw a patient offhand and did not get paid due to no referral with a visit count towards the attribution methodology, we talked about that one, and it does go back. The attribution does go back for 2 years.
Mm-hmm.
So if a patient only has pregnancy Medicaid and we are the only physician they see, will we be creating their referral numbers?
You would fill out a referral form, the Form 362, and what that form would allow the specialist to do is bill with your NPI number. So I'm not really, the referral number is not, there's not a referral number per se, but it is your NPI.
All right. If a therapy provider has to obtain a referral for ACHN, what is the turnaround time for that referral? We currently receive EPSDT referrals from patient-first providers, but have a patient that's currently not assigned to a PCP. So in that situation, the ACHN does have the ability to provide a temporary referral for you, and I would work with that ACHN that the recipient's assigned to. What is the turnaround time? It depends upon each ACHN, and that's a question where you need to have a conversation with that ACHN. But you would, even if the patient doesn't have an assigned PCP, they still technically could have a PCP they are attributed to based off who they've historically been seeing. So I would still just check that, the web portal, because that patient might have a PCP still attributed to them who you could reach out to. If a patient is at a specialist but has not seen us, and the specialist is calling for a referral because they are saying that we are the PCP, are we required to give a referral? Well, moving forward, the only time a patient would show up as being attributed to you is based off of prior history. So if they are attributed to you, your practice, then somewhere, sometime in the last 2 years, you saw that patient. What if you're attributed to a patient and the patient sees another PCP and needs to be referred to a specialist? Who would do the referral, the attributed PCP or the treating PCP? Either one of them could provide that. It is up to that patient. That patient could have been attributed to a PCP from the previous history, but they decide they don't like that current PCP and they're trying someone new, and that's who they're seeing right now, and because they don't have 3 months of history or enough visits, they haven't had a high enough score for that patient to be attributed to them. So at that case, that's why we've said any PCP can send a referral. The one that's been attributed to them or the one that they are referring who has sent them to you. And that is the last of the questions that we have had entered in. Would anyone like to make any closing points? Melanie?
We'd like to thank you so much for your attention today, and just a reminder that today's webinar was recorded. It will be posted on the Medicaid website. The pathway to get to that is to click on the ACHN tab and then click on the link for ACHN Providers. Most of the information, both today's presentation and any past recorded webinars, will be listed there as well. Thank you, and I hope you have a great day.